So I've got about half an hour. I'm going to try and talk through the background to pelvic radiotherapy, why we give it, and why some of the problems happen. And then the main bit of the talk for about 10 minutes is going to be talking about the technical changes in radiotherapy, how the improvements in the machines and how we're using machines hopefully will improve outcome. And then about 5 minutes at the end about other approaches that are going on. I'll try not to talk too quickly. I'm guessing you're not a particularly radiation oncology specialist group, so there are some bit of technology. I can't get away from that. It's what I do, what I love. So why do we use it? So radiotherapy is very potent, it's very cost effective. It's used in probably up to 50% of patients throughout the cancer journey, and we think that 50 to 60% of patients who are cured of their cancers benefit from having radiotherapy. Therefore, a very large number of patients have radiation across the UK each year, about 100,000. It's relatively low budgetary impact on the health service at the moment, but because so many people get it, it has so many roles, small changes can make a lot of benefit. So there is a huge scope to improve cure rates and or reduce toxicity. Now, ASCO, they've had a lot of press release about immunotherapy drugs, which are fantastic, and potentially immunotherapy drugs will work very well with radiation. Radiation is immunogenic. So I don't think radiotherapy is going to go away. Our challenge is trying to make it better. So what is radiation? Well, it's basically the therapeutic use of ionizing radiation. So in this little schema, hopefully you can see that, you've got a bit of radiation coming into the tissue, causing local tissue ionization, development of free oxygen radicals, which are highly reactive, and they cause reactions on DNA. And what you tend to get, or what you want to achieve as a radiation oncologist, is double-stranded DNA breaks, which the body isn't great at repairing. And those double-strand DNA breaks leads to upregulation of lots of intracellular pathways, damage, recognition of the DNA damage, and one or two things: repair, which you hope happens in normal tissues, and cell death, which you hope happens in cancers. So that's basically what radiation is in a very simplistic way. So how do we give it? You probably know this already, but there's three main ways. The first one is external beam radiation. That's what I do predominantly and what the talk is going to be based around. And basically over the last 70 to 80 years, there have been lots and lots of technical developments in radiation. So you had a low energy machine that gave its dose mainly on the skin. 30 years ago, you had high energy machines, linear accelerators, which give the dose more deeply. And then about 20 years ago, development of movable devices in the treatment heads called collimators that can create any shape you liked. And associated with that, you had things like IMRT, I'm going to tell you about in a moment, when you can move these during treatment. And you have quite complex machines that can rotate around a patient, treating a patient in an arc therapy called tomotherapy. And in the last 10 years, you've had more sophisticated robotic techniques called cyberknife, and coming up in the next 3 years in Manchester and UCLH, protons, and possibly in Cardiff, but we're not meant to mention that. So there are a lot of developments happening. That's my only politically sensitive talk today. Okay, so then you've got things like brachytherapy, which is different. It's implantation of radiation directly into the tumour, and it can be basically done in one of two ways. On the right-hand picture, you can see implantation of radioactive seeds for prostate cancer, which stay there permanently and deliver a dose over about 3 to 6 months. And you have these tuber ovoids used predominantly for cervical cancer. When you temporarily put the radiation tubes where you want the radiation to go, and then radiation gets pulsed in and out for about 20 minutes, half an hour, 1 hour. And that gives a much higher dose very locally. And again, not for this talk, we also can give radiation by injecting it. So if we know somewhere of targeting injected bloodstream radiation to a cancer, in this case is a patient with prostate cancer with bone mets, and we can give injected radiation, it goes to those areas, increase activity, and that can help to improve survival as well. But this is mainly about external beam radiation. So what about radiation for pelvic cancers? Well, it can be used for palliative purposes. So if you've got patients bleeding, in pain, radiation can be very effective. But predominantly this talk is about curative radiation. And curative radiation can be done either the primary treatment, so a locally advanced cervical cancer, maybe anal cancer we've heard about, or prostate cancer. It can be done neoadjuvantly, so very large rectal cancer that can't be operated on. You can give 5 weeks of chemoradiation, you can shrink the tumour down, and they can have a curative surgical procedure. Or we can give adjuvant, so the patient's had a surgical procedure, they maybe got some involved lymph nodes, and you're worried about relapse, and you can give radiation after surgery to reduce the risk of disease recurring. And I've shown here we can also give radiation in combinations with other therapies. So what are we trying to treat? Well, from the curative discussion, you can see we're either going to treat the main cancer bulk or spread around it, but we often are treating the pelvic lymph nodes, and that's, again, I'm going to talk about this IMRT. And it's the pelvic lymph nodes that we're treating for a lot of different tumour sites. And you can see we treat just about any tumour: prostate cancer, endometrial cancer, cervical cancer, bladder cancer, rectal cancer, and the rarer anal, penile, vaginal, vulval cancers, sarcomas, lymphomas, all will have radiation as part of their management. So we estimate that about 17,000 patients receive radical pelvic radiotherapy a year in the UK, a very large number of patients. So why do we do it? Well, this is one bit of data. This is from the prostate world where I live, a trial called PRO7, or international trial called PRO3. Patients with locally advanced prostate cancer, historically, patients were treated with hormone therapy alone. And this is a survival curve. And the blue line is patients surviving just with hormone therapy alone. And the trial was adding in radiation. Most patients had pelvic radiotherapy, and that leads to the yellow line, basically more patients being cured and living 5, 10, 15 years into the future. So radiation in this group of patients in the last 5 years, we've worked out, cures patients who weren't otherwise being cured. Therefore, we're going to be using radiation for the future. But this is CT slice through the pelvis. The lymph nodes are there. Well, that's clever. Basically living in the horseshoe area around the blood vessels, around the blood vessels on the outside of the pelvis. And in the middle, you can see the normal structures. So you've got a bit of bladder, just where the arrow is, and lots of loops of bowel. And that's the problem. Where we're radiating has normal structures. And at the moment, we can't completely avoid it. And I'm going to give you some slides to show how we're going to make it better. Now, because of that, we cause problems. The dominant problem that we know about is long-term bowel problems. It's not the only problem. We affect sexual function, urinary function, skin function, nerve function, but it's predominantly bowel. So there's done some work which has suggested that 90% of patients who irradiate have a permanent change in their bowel function, and that 40% of patients will be moderate or severe. And the range of bowel problems is very broad, and it won't necessarily affect every patient, and different patients will get different patterns of that. Now, I think that's poorly appreciated by oncologists. I don't recognise that number of patients, I'd say, from my clinics, that I'm causing that level of problem. I'm going to show you how wrong I am, but I think there is a problem. I don't think we recognise it. Because we don't recognise it, we don't necessarily try and do anything about it. So there are a few active management programs where we are actively looking for problems and addressing it. And I'm going to show you in the last 5 slides how we are trying to reverse that. So one of the reasons why I don't necessarily recognise it is when I look at my papers, and this is actually a quality of life paper came out last week on PRO7, looking at the mean symptom scores over time, over 5 years of patients looking at either all bowel, quality of life data, I think it's the RTC, or diarrhea specific. And there is a separation in the curves. This is mean scores up to about 2 years, and then it seems to be the same. And I think it's quite hard for me to appreciate what that might mean for a patient. Because to some extent, I'll be quite reassured looking at the end and think, well, after a couple of years, they're the same. So I'm not sure the data, the way quality of life data is always presented for an oncologist. We like snapshots. I don't necessarily appreciate it. But we are doing some work locally trying to actually work out what we can do to make it better. So we've done a small study. It's going to be presented next week for the first time, looking at patients who've had pelvic radiotherapy, and we've done a snapshot 12 months after pelvic radiotherapy to look at their toxicity. So we've used the Christie self-completed lymphoma questionnaire. We posted it out to patients. A research fellow, Rashmi Jadon, did this. 300 patients we wrote to, and 200 patients got back, which I think is pretty good. Mainly prostates, and I think that just represents the numbers of patients coming through our clinics. And what we've shown is that, in this chart, red is people with grade 4 toxicity, and the dark yellow is people with grade 3. So that is showing that in our group of patients, 40% of patients are having grade 3 or 4 severe or very severe toxicity 12 months after radiotherapy. So there we go. I didn't believe it, and now I'm going to have to try to believe it, and we're looking into this in a bit more detail. It does look like most of this is one symptom, which is urgency. We don't have baseline data. We don't know how it's going to change over time. We don't know quality of life. We don't know how patients are coping with it. So it's a real problem. And first of all, we've got to recognise it, oncologists, and then we've got to allow patients to tell us so we can do something about it. So we've got to do better, and now I'm going to tell you how, from a technical point of view, we're trying to get better. So you know a little bit about the radiotherapy process. I'm not doing this in a lot of detail. It starts with taking an image, a CT scan of a patient usually in a treatment position, using all the diagnostic imaging to outline what we want to treat, and then outlining the normal structures that we want to avoid, and then going through the treatment planning process, which is basically these days is a pretty complex, computerized process where we're trying to optimize for each individual patient based on their anatomy, the coverage of the cancer, and avoidance of the normal structures as much as possible. And then we go to the treatment position where we want to deliver the treatment, and the treatment is usually delivered over 5 to 7 weeks. So we want to make sure the treatment, which is now very complex, is delivered accurately in terms of the technology and physically accurately. And I've got some slides on that as well. And most of what I'm going to talk about now is about the treatment planning process and the treatment delivery process, how we can make it better. So the first thing I'm going to talk about is intensity modulated radiotherapy, which has basically been my career for the last 15 years, which is basically trying to improve the avoidance of normal tissues. That's the predominant aim of it. So if we go back to this slide, we've got the lymph nodes around the outside we want to treat, the bowel in the middle we want to avoid. To treat those lymph nodes, we can't always see them. We create sort of an area roughly where we think the lymph nodes will be because we can't see them on an individual patient, maybe post-operatively. And historically, to treat that, bearing in mind that every different slice of a patient is different and changes, and the anatomy changes every so often, we've always historically put a box around it, or a cube-like box, and everything in the middle gets irradiated because that's what we've had to do. With the development of those little leaves, we can shield out the corners. On every slice, you'll get a different pattern of the leaves, and the pattern of what you shield from the outside varies. So that's conformal radiotherapy. You don't get any risk of missing a tumour, but you do avoid some normal tissues. But you couldn't get into the bit in the middle. You couldn't create a dose concavity to avoid where the bowel is. And this is the same for head and neck cancers. You've got parotids, you've got spinal cords. To create that concavity, to avoid the normal structures, you need IMRT. And that's basically what it does. So IMRT is delivered from multiple different directions around the patient, usually 5 or 7. It's quite slow, it's quite complex, maybe takes 15 or 20 minutes to deliver. And more recently, we've developed a technique called VMAT, which is basically a rapid arc. Whips around 2 minutes, even better than IMRT. And so I'm not sure how well you can see. This is a standard prostate and pelvic nodal IMRT or VMAT plan from Velindre. So the last sort of 18 months, all of our prostate patients have had this VMAT solution, this type of VMAT solution. I'm not sure how well you can see it, so I'm going to try to show. The top is the bowel, which we outline every single slice in every single patient. Then the purple bit in the middle is the lymph nodes, which is that sort of structure I've mentioned from before. And blue, the light blue line is basically the dose delivered, and in particular in the middle, you may not see this, but the blue line, the dose, completely matches the purple line, which means that all the lovely normal structures in the middle are reduced in a high dose volume. They don't get zero dose, but they get a lot less dose than they used to, and this should improve outcome. You can also see here that there's some patients who've got some involved lymph nodes, which, again, 5 years ago wouldn't be treated, but we're being quite aggressive in Cardiff, and we're giving that a slightly higher dose, and we're giving a boost dose, all within the same plan. It takes half an hour to create, 5 minutes to treat a patient. So it's very complex treatment compared to what was done before. So that's one of the advantages of IMRT. IMRT does come with its own problems. Before, we just treated a box. So it's quite easy to do that. You just put the box on, took about 5 minutes. Now, on every single slice, you need to outline all the normal tissues you're worried about. You need to know where the lymph nodes are. So you've got to relearn your anatomy to know where the nodes are, how to do it. And it changes every single slice. It's incredibly complex. It's about an hour and a half to do it. There's a lot of risk of variation from doctor to doctor, centre to centre, country to country. So there are international guidance. And any trial we do has this radiotherapy trials quality assurance group I'm heavily involved with to make sure that doctors are doing it properly. Very high quality. And then you get these very complex volumes you're creating. But also, you've got a very sophisticated treatment. You've got a machine arcing around quickly with very lots of moving parts. You've got to make sure the delivery, the techniques, the physicists, the people and the machines are giving the treatment accurately. It used to be slower. So if you were treating 10% of your patients in 5 minutes, and now 25 minutes, you need more machines to do it, which is a challenge. But fortunately, this rotational VMAT is even quicker, so there are solutions to technology. But the potential benefit is huge. Potential benefit across all the pelvic cancers and actually across most tumour sites. So one of the challenges we're trying to do is to introduce IMRT, because this is a lot of patients around the UK. So we've been doing quite a lot of work, and this is a paper published 3 years ago, basically looking at the proportion of radically irradiated patients in the UK being treated with IMRT. So 7 years ago, it was about 2%. We had set a target of 25% by 2014, and there was quite a lot of money and training went into this. So there appeared to be signs of an exponential increase by 2012. We're on track. We've just updated the work, about to be published in a report, and hopefully published in Clinical Oncology. And now, well, last year, across the UK, 36% of all patients in the UK radically irradiated were getting IMRT. And this is national figures, so this is absolutely huge, complete coverage of the whole of the UK implementing new technology. So exactly what we want to do. Clearly that's going to plateau out at some stage. Most of us think this year. So that's good. It's not going to stop with IMRT. IMRT uses something called photons. And what's coming next are protons. And protons have a slightly different type of radiation. You basically don't get much dose when it goes into a patient. All the dose gets delivered in the last bit, and then there's no dose at all. And you compare that... Sorry. I'm not going to do this. So you compare it to the slide on the right, and you can see that in this situation, the protons are in blue, and the photons we're doing at the moment are in the red. And basically, with the photons we use with IMRT, most of the dose gets delivered at the skin, and the dose falls off gradually. So if you've got protons, and you've got a tumour you're treating 10 or 20 centimetres into the patient, then ideally you had that protons, and you had that peak, and you blur it out a little bit, you can get a really, really high dose around the tumour and nothing else. So if you look at this prostate pan at the bottom, you can see where I've got my slides from. You can see that with the IMRT treatment, the high dose in the prostate in the middle is more or less the same as the protons. But with protons, you get very little dose into the rest of the patient. So you actually need less radiation to treat the cancer. And so for the prostate patients, it probably doesn't make a lot of difference with generally treating fat, bone. But if you're up in the pelvis, you may be treating a lot more bowel to low dose, but we don't know how important that is. So if you look at a comparison of IMRT versus intensity modulated proton therapy for, in this case, cervical cancer, again, the slides on the left are the IMRT, the slides on the right are protons, and I'm going to try to show you that even with IMRT, you're getting a bit of dose falling off into the bowel, and the protons, the dose is lower. Particularly higher up, you get quite a lot of low dose into the bowel, and with protons, that is reduced a lot. Problem with protons, they are incredibly expensive. I think it's £250 million for 2 machines, so they are coming to the UK slowly, but there is a lot of potential benefit going forward, I think for pelvic tumours in particular, in trying to avoid bowel toxicity. So the next thing we're going to talk about for about 5 minutes is image-guided radiotherapy, which is really more to do about the accuracy on set each day of treatment. So basically, if we're delivering a highly accurate treatment, very conformal, hitting the tumour, keeping away from normal structures, you've got to make sure that every day you're going to the right place. Because before, with a bit of dose going left, right and centre, it didn't matter so much. But now you actually get it right. And it's particularly complicated within the pelvis, because you've got a lot of moving structures. Bowel, rectum, bladder and uterus, they all move around, mainly because of rectal and bladder filling. The movement is unpredictable. It varies from day to day. It varies from patient to patient. It can change in just 20 seconds. And sometimes it will affect the normal structure you're trying to avoid, but sometimes it'll be the bladder with a bladder cancer, and it's a cancer that's moving. So every single clinical scenario needs to be dealt with differently. So it's not quite like IMRT, we do the pelvic node for every single pelvic tumours. This has got to be worked out. Each different cancer type, what are you trying to achieve? So it's taking a little bit longer to introduce image-guided radiotherapy, but we can do it. So for prostate, it's relatively easy. This is not a great picture, but what I'm going to try and show you these slides. The slide on the left, you can see a very large rectum. And the slide on the right, the rectum is empty. And for a lot of patients with prostate cancer, that means the prostate can move by 2 centimetres. And the prostate, we're trying to be accurate within about 3 millimetres. So actually, it's internal organ motion, rectal filling, is the biggest problem for prostates. There are things you can do about it. in terms of preparations and enemas and dietary things, but even so, that still changes. Now, the prostate's quite easy. It's basically a ball, and the ball moves around. It doesn't really deform. So as long as you know where the ball is, and you've got a radiation dose that can match, and you know where they are, you can move the dose around to hit the prostate. In the past, we put margins around it so that we never missed, but the margins have to treat normal tissue, and they treat the rectum, which we want to avoid. So if we're trying to get better imaging, more accurate, knowing where the prostate is, the answer is we'll be able to reduce the margins and reduce normal tissues being irradiated and reduce side effects. So for prostates, what you do, you put gold seeds into the prostate, which is an invasive procedure. You can then image on a daily basis with either an X-ray system, or what I'm showing here is a slightly more complex cone beam system. You can actually see the prostate, see the seeds every day before treatment, see, image, treat. You don't need to put so many margins around it. Unfortunately, it's actually quite complex introducing a service of putting fiduciary markers into patients, and it's not done routinely in the UK at the moment, but we are working on it. The benefit would be predominantly reduced side effects because we can reduce the margins. So I've mentioned cone beam CT. So this is basically, you might not need to put fiduciary markers in, invasive procedure. You just do a quick CT on the treatment machine, and you can see on the left, you've got the image of the planning scan with a big, big rectum. And then 4 scans on the cone beam scan taken on the treatment set before treatment. The image quality isn't quite so good. You can't see the prostate brilliantly, but you can see the rectum. And hopefully you can see that on 2 of the days 1 and 4, the rectum is full. But on 2 of them, day 2 and 3, the rectum is empty. And particularly in day 3, I can see, you can't see, but the prostate is fallen outside of the high dose area. And that patient would fail treatment. And there is evidence, there's 2 really good trials that shows that patients who've got a full rectum in the planning scan have a worse tumour control rate than if they have an empty rectum. So it is a real problem. So when you've got CT scanners on treatment, you can use it quite cleverly. So the next tumor site I'm going to talk about briefly is image guidance for bladder cancer. So again, these are 2 slides. This is from a paper from the Marsden. And you can see that the bladder volume has changed a lot. Now, if you had this was your original treatment, and you had your cancer at the top, and then during treatment, the bladder reduces its size, then within the original treatment, you would still treat the cancer, but all this lovely normal structures, all this lovely bowel would fall into your high dose area. So bladder movement can lead to missing a tumour, but can also lead to too much toxicity. And the bladder can move 5 centimetres from day to day, depending on patients. It's very hard trying to get a consistent bladder volume, but what we can do now is to image in each day. Now, one of the problems with the bladder compared to the prostate just moved around, the bladder changes shape. So it's slightly harder to work out how you're going to deal with that from a technical solution. And the solution, which is done originally from the Christie, now at the Marsden, something called Plan of the Day. So what you do, for each patient, you do your planning scan on the left, you outline your bladder, and you create 3 separate plans for each patient, one assuming the bladder is going to be empty, called the small one. One's assuming the bladder is going to be midfilled, called the medium one. And one assuming the bladder is going to be very full, called the large one. So each patient planned 3 times, the plan's completely approved, ready to treat the patient, and each day of treatment you do a CT scan, you see how full the bladder is, and you pick your large, your medium and your small, depending on what is the best anatomical fit. And what that should mean is if the bladder is empty, you don't irradiate unnecessarily bowel, and if the bladder is full and big, you don't miss the tumour. So this has now gone into clinical trials. So in the UK, we tend to do things with clinical trials nationally, and there's about 10 centres taking part in a phase 2 study of this, looking at reducing toxicity. And there's about to be a larger trial called RADAR coming through, looking at improving cure rates of radical patients. Other centres are actually just treating, other countries just treating it. We're doing it within trials. And this sort of issue also happens for gynae cancers. So for cervical cancer, again, this is another picture, this time from Erasmus in the Netherlands, when you've got the cervix and the uterus in orange. On the left-hand side, when you've got a very full bladder, and on the right-hand side, we've got an empty bladder. And you can see that the uterus tilts, and it can tilt by several centimetres. And if you want to treat that, then you need to put large margins around it to compass it. And those large margins include normal tissue. So again, a solution, a bit like bladder cancer, we think is the way forward, is to have multiple plans approved for each patient, one with an empty bladder and one with a full bladder, and each day you do your CT scan and you pick the right treatment. These are complex things to do. It takes a lot of time, it takes a lot of training of the radiographers on the sets to make sure they can image accurately. And this is going on in Erasmus. And what you can see with this slide, hopefully, is on the left you've got the planning scan, and on the right you've got the cone beam scan. It's not such good quality, but you can, certainly my slide here, you can just about make out the bladder is emptier and that the cervix and the uterus have moved a little bit. So that clinical programs are going in Erasmus. It's not been done routinely in the UK, but I think it's the next step with the plan a day for cervical cancer. So that's an indication of the complexity that we're faced with, but we are working on it. So for about 5 minutes before I get my yellow card, I'm going to touch on other approaches. So first one, a little bit about biology, and this is just concepts. So we don't really, I don't think, understand how radiotherapy affects the bowel. If we did, then that would be fantastic. We don't really understand what part of the bowel is dominant, causing different symptoms. So I now know that the dominant problem is urgency, and I'm not quite sure what part of the bowel causes the urgency that I could therefore avoid with my technology. It'd be great to have drugs that protected from radiation, but they've got to be drugs that protect normal tissues but don't protect cancers. And there isn't really anything that is, I know of, that's coming into routine practice. Amifostine has been discussed but hasn't come in. And of course in the bowel we could maybe find drugs that protect normal bowel, and that might be easier, but again there's nothing particularly that is routine. And what's increasingly coming through is maybe it's the bacteria that are very important, and actually as we irradiate the bowel, the normal intestinal flora changes, and that could be potentially protected, or potentially after treatment could be renormalised, and there's interesting suggestions of how that could be done. And that's been reviewed in a paper which I'd recommend you want to read out if you want to look at treatments. So then, how can we predict for late toxicity? So I know that patients who've had surgery, who've had inflammatory bowel disease like Crohn's disease, ulcerative colitis, will have bowel stuck down in the pelvis, it'll be there the whole time. And those patients get very bad, severe toxicity during radiation and are much more likely to have problems afterwards. I also know that if we do that original planning scan, you've got a patient with lots of bowel down there, they're much more likely to get bowel irradiated throughout treatment. But what I don't know is that with bowel moving around, how important it is to just define your treatment of a single scan, or should we try to add up all the scans, all the dose throughout the whole of treatment? And that is work we need to understand. There's then a little bit about genomics, and I've got 1 or 2 slides on this, and we do know that there are variations in individual patients' responses to radiation. So this is a slide that's been given to me by Neil Burnett from Cambridge, and he's leading on something called RAPA. And basically this graph is going to show a spectrum of radiation sensitivity. On the left-hand side, you've got a patient who's got one gene, ataxia-telangiectasia, incredibly sensitive. And you've got a couple of other genes that may be predictive of severe toxicity, but most of the genes are going to have just a slight increased risk. So for most of the population, you get this range of maybe a highly sensitive patient, low sensitivity, and median. And at the moment, we don't understand why. If we could categorise patients, that would be a very useful tool, and we can maybe talk to patients and say, well, you've got 5 of the 10 genes that give you slightly higher increased risk of toxicity. You've only got 1, so we might be able to manage them differently. And we'd have to work out how to manage them differently. I mean, what would I do with a patient who I thought, you've got a higher risk of radiation toxicity than average, but you've got a big cancer in your pelvis, so I've got to treat you anyway. And what do I do about it? Do I not treat them? Well, if they've got a choice of having surgery, you may not irradiate them. But or we may say, well, this patient's got to go off to America to have proton therapy. So we don't understand that. How do you manage a patient who's got a lower risk of toxicity? You've got no of the radiation risk genes, therefore, maybe I can give you a higher dose, and I can give you a higher chance of curing. So we've got to work that out, and that's going to be quite interesting to see how we do the trials for that. But then what happens if we've got a patient who gets very severe toxicity during radiation, or after radiation has very bad toxicity? What do we do then? We can't necessarily stop the radiation halfway through because they don't get any of the benefit. And we probably need to develop treatments that can sort of recover the damage, or maybe we can, as soon as they finish the radiation, if you have these treatments, then we will prevent you developing late problems. And then the last few slides is how do we manage patients with established late toxicity? And that we're going to talk about. So the first thing, you need a team. You need to actively seek out your problems. So you need your oncologist to recognise that bowel problems are a problem after radiation. We need to actively ask our patients, because I don't think I've got any clue from the patients I've been seeing routinely that they've got a lot of bowel problems. We ask them, they do. So there's a disconnect between myself and the patients. We then got to get a gastroenterologist interested who wants to see our patients, and there are a lot of patients, so he's got to do it on his own. So he's got to get a local interest group so he can make sure it's not just the patients in Cardiff, but it's the patients in Bridgend and Newport and Swansea, all who access the same care. And we need to try to support them. Now, there are other people out there. Jarvis Andreev, you may have heard about, is a gastroenterologist who is smiling in this talk. Usually he's swearing at oncologists, but he's sliding here. And he's done a lot of work funded by Macmillan and others. And one of the things he's developed is this algorithm, which basically means that anyone with a bowel problem after radiation gets referred to a gastroenterologist. And whatever the bowel symptom, be it diarrhoea, that doesn't help because there are all sorts of underlying pathologies that can cause diarrhoea. So they've got to be evaluated very systematically. And he's done a trial which shows if you have that, you don't need necessarily to have a specialist consultant gastroenterologist managing patients. You can have it based at a CNS. And the British Society of Gastroenterology has taken this algorithm and the CNS driven service as one of their priority areas to take forward. But actually it's quite difficult doing that. The Orbit trial was done at the Marsden, and the Marsden is wonderful, but it's not the same as Cardiff, and it's not necessarily the same in a routine setting. So we've got some funding, which Sam and I are involved with, called the Eagle Study, it's funded by Prostate Cancer UK, to try to develop and implement the algorithmic approach done by the Marsden in effectively non-specialist centres by supporting non-consultants so that we can actively seek out patients with bowel problems. People with bowel problems get referred into CNS and they follow the algorithm, and then we're following them over 12 months looking at their quality of life. I'm glad to say that Macmillan are funding a couple of the centres to look after non-prostate patients so that the centres will get an overall benefit. And that's going to be Cardiff, Sheffield and Brighton. I think Sheffield and Brighton are open and we're going to open in the next month or so. So that is what we're doing locally. And that's sort of what I'm going to stop at. So pelvic radiotherapy is incredibly important for patients. It helps cure patients, but at the moment we can't completely avoid normal tissues. We are working very, very hard to try to use current technologies, but as we're getting better, I'm effectively treating less fit patients, or I'm treating bigger volumes because I want to cure patients with cancer. And we do need to try and develop new treatments for patients with established problems, working with Jarvises of the world. How do we maybe treat patients who've got established acute toxicity? And we need to work out how to deliver the best care now. The Marsden are doing it. I want to be doing it effectively. And then somehow we need to understand why some people get problems and why some people don't, and then maybe work out how to be more intelligent going forward. And that is where I'm going to stop.